There are many health issues a lot of us are too ashamed or too afraid to talk about. You know the type, pretty much anything to do with genitals, pelvises, and sexual health. It's embarrassing to admit to a friend or even a doctor that you can't get an erection, or you're constantly up all night peeing, or you're experiencing vaginal dryness. But is embarrassment worth making yourself sick over, or worse? Many of these problems can actually indicate a bigger issue going on inside your body, but we're ignoring the signal. I'm Dr. Karan, an NHS surgeon, and in this podcast, we cut through the BS of modern health advice and tackle the biggest issues in science and medicine. Today, I'm joined by Dr. Rena Malik, a board-certified urologist, pelvic surgeon, and sexual health expert. So if you want to understand your body better, or you've got any concerns about what's going on down there, this episode is chock full of advice. And hopefully, by the end, you'll feel a little bit more comfortable talking about everything. Enjoy.
Rena, it's so good to have you here on my podcast. And I feel like, we've followed each other for so long online, and I feel like I'm your friend, but this is the first time we're actually interacting, face to face.
Yeah, I feel the same way. I've been following you forever. I love your content. I love that, there's not a lot of surgeons like us on social media
Yeah.
who make the time to be a surgeon and still make content. So it's really great that you're doing this and you're changing the world, and it's amazing.
No, likewise. And obviously, as a pelvic surgeon and urologist yourself, when you see patients coming into your clinic with, obviously a variety of urological issues, urinary issues, pelvic floor issues, what are the most common things that you see?
It's so variable, but a lot of what I see is bladder related. So urinary incontinence, overactive bladder, which is basically having like gotta go, urgency, waking up at night to urinate. For men with enlarged prostate, having difficulty urinating, meaning having to strain or push or feel like they're not completely empty. So that's a lot of what I see. But I also see a lot of sexual dysfunction in my clinic. A lot of men with erectile dysfunction or premature ejaculation or a variety of things like low testosterone or hypogonadism. And then women with, difficulty with libido or orgasm, or like what we call genital urinary syndrome of menopause, where they start having symptoms of vaginal dryness or discomfort or pain with sex, that sort of stuff.
Obviously, although we're not in the same specialty, we cover a lot of similar things probably in the patients that we see in the surgeries we do. As a bowel surgeon, the pelvic floor, the pelvic muscles, fecal incontinence, constipation, all of these things have some overlap with many of the things you do. And, when we're talking about either bowels or genitalia or sexual stuff, all of these things are very taboo. Things to do with the toilet, things to do with the bedroom, things that we sort of hide and try to shove away somewhere. It has this inherent taboo for whatever reason. People think it's dirty, it's awkward. And I feel sometimes a lot of people are literally dying with embarrassment. In the case of colorectal cancer, someone could be having bleeding when they're going to the toilet and they think it's a awkward issue, and they could be bleeding to death slowly and dying from colorectal cancer. I guess similar in your instance when the point you mentioned about prostate issues, for example, a classic marker of maybe a sort of a prostate problem, maybe even prostate cancer, could be someone urinating more frequently or having issues with urination. And it's a bit of a embarrassing thing that a guy's not going to speak to his male friends about. How do you sort of navigate that taboo and actually raise more awareness of that so we can be more comfortable talking about, penises or genitalia or prostates in this case?
Yeah, I think on an individual level, of course, it's, making the person feel comfortable. Like this is something we do every day. Sometimes it just means like asking the patient, about all those things because they won't bring them up unless you do. Right. And I think that's the major issue is sometimes you just have to build that rapport with the patient. Now, on a larger scale, of course, I think what we're doing here is trying to encourage people to talk to their doctors when they have issues, because even something you think that may be really slight could be an issue, right? So for example, when you think, oh, I'm just leaking a little bit, I'm just having a little leakage, it's no big deal. But there are really severe downstream consequences in terms of quality of life. And people are like, oh, who cares? I'm not dying necessarily. But you may be preoccupied with what it smells like, what it feels like. You may be going to the bathroom quite frequently, so you can't get as much work done. You might avoid social outings because you're like, oh, I can't go to the movies. I can't sit through the movies. And so these things then lead to depression, anxiety, or falls when you wake up in the middle of the night to pee. So I think it's just really important to say like, hey, it's important to see your doctor if you're having issues and then make a decision if you want to do something about it, right? You don't have to take a medication. You don't have to have surgery for things like that, right? Like I know my patients get nervous around me because this is not their normal, right? They're not undressing and like showing their genitalia to a complete stranger like on a regular basis. But on the other hand, I am looking at genitalia and examining people every single day, multiple times a day. And so realizing that like for us, it's not something that is uncomfortable, and we should be making you as comfortable as possible. And if at any point in time you feel uncomfortable, just say so. Like we will stop whatever we're doing and we won't do it. And you can always say no, thank you, I don't want an exam if that's really what's holding you back, and just talk to the doctor.
I was wondering if you can just give us a very basic primer on the organs that are typically found in the pelvis. And when people hear the phrase pelvic floor, what exactly is the pelvic floor? And specifically, what are the differences between men and women in terms of pelvis?
Let's start from the internal organs. So you have your rectum, which you are very familiar with, Karan, and the
What a
bladder. And then
sentence.
for women, and, and then for the bladder, and then for women, you have the uterus on the inside. Those are obviously for us, the bladder is connected to the ureters, which go up into the kidney. So that's all part of what we call the genitourinary tract. There's also, of course, all the structures that go through the pelvic floor, which are, for women, the vagina, for men, the urethra, the prostate, and for men, well, the pelvic floor includes the genitalia, like the testicles, the vas deferens, the seminal vesicles. These are all internal. Some of these are internal structures, and so they are all part of a normal, healthy, functioning genitourinary tract. Now, in terms of the pelvic floor itself, this is a bowl of muscles that is basically holding up all those pelvic floor structures. So it's underneath the bladder, around the urethra, around the rectum, around the vagina, and around the rectum for men is how we examine it. So the difference is that for women, we can assess the pelvic floor through the vagina, right? Because the pelvic floor is right around the vaginal muscles, around the vaginal skin, and it can cause issues in terms of those structures. What if it's too tight in women or men? You can have experienced issues like urinary urgency, urinary frequency, gotta go, gotta go. You can have constipation, which you're very much familiar with, and you can have even back pain or hip pain. In women in particular, you can develop, when it's too weak, you can develop pelvic organ prolapse. So what that means is that those structures inside are pushing down and causing basically a hernia, so a weakness. So you see a bulge potentially, and that may be the top of the vagina where you'll see the uterus coming down, the front of the vagina where you see the bladder coming down, and the back of the vagina where you'll see the rectum pushing down. And in men, when you have weakness, sometimes that can contribute to some rectal prolapse, although it's quite rare. And then when you have tension in men, all the same symptoms, but sometimes you'll have pain with sex, and that's in both genders. You'll also have pain with erection, pain with ejaculation, or testicular pain. And so it's a really important area to get evaluated because a lot of times people don't even know they have an issue there. It's sort of like TMJ when you're clenching down at night and getting pain and waking up with headaches and you have no idea you're doing it. The same thing, you're clenching your pelvic floor as sort of a stress response or
Yeah.
in a response to sort of dysfunctional behaviors. And then, you don't even know you're causing these issues and you actually need support and help to learn how to train your pelvic floor to then function normally again.
I guess one of the things which, again, it's an embarrassing topic for many people, particularly many men to talk about, is erectile dysfunction. It's something which is a physical problem, maybe also partially a psychological problem, but it's not something that they would necessarily talk to their friends about and, may not even feel comfortable bringing it up to their doctor just because it, I guess, psychologically makes someone feel less than. How common is that? And what are the real culprits behind something like erectile dysfunction?
Yeah, so ED is very, very common. It's in 52% of men over 50 years of age. So more than
Wow.
half of men over 50 will experience ED. And you're right, men don't talk about it, right? When women have issues, they will talk to their girlfriends a little bit about,
Hmm.
oh, I might leak a little. This is so annoying. I mean, of course, there's still that embarrassment, but if you have a close relationship, women do tend to talk about those things. Whereas men never talk about them to their friends or anyone really, even their partners. Sometimes they will just, sort of cope by avoiding sex instead of actually talking to their partners sometimes. And so it can be really, really psychologically scarring for a lot of men and really devastating because they don't go talk to their doctor, or if they do, they just are given some medications and really not don't understand the underlying cause. And so when you think about underlying causes, there's pretty much five major causes. Most common is vascular dysfunction when it comes to an organic cause. So things like if you have high blood pressure, diabetes, high cholesterol, all
Yeah.
those things are going to affect essentially blood flow, right? And the arteries to the penis are about 1 to 2 millimeters, when the arteries to
Mm.
the heart are 2 to 3 millimeters. So long before you see issues in your heart, like chest pain or heart disease, you're going to start seeing issues in your penis. And so this is why it's really important to get evaluated, because not only will you potentially fix your erectile dysfunction, but you might save your life, because 15% of men who have ED will go on to have a heart attack within 7 years because of this vascular
Wow.
etiology. And so it's really important to get evaluated and potentially, ideally, optimize those risk factors before you get to the point where you're now building up plaque in the arteries to your heart, leading to a heart attack.
So actually, in that case, you could even argue that if someone is experiencing a sudden decrease in the frequency of their erections, whether at nighttime, in the morning, the morning glory, it might be a warning sign, or at least in sort of an early alarm bells that maybe you want to check out your heart health.
Absolutely. Absolutely. 100%. I tell all my patients that you need to be evaluated. I check a lipid panel, we make sure their blood pressure is okay, and they see their primary care doctor, or if they have a cardiologist, to see them. So it's really, really valuable and really important. And the way to reverse the ED is to fix those issues, right? To fix
Hmm.
ED, to fix diabetes, to improve your cholesterol. That's going to improve your erections, right? And do what's good for your heart and good for your brain is good for your penis, right? So exercise, in fact, 150 minutes of aerobic exercise every week, moderate intensity, will improve your erections as much as a pill like Viagra. So
Mm.
really, it is challenging, but there are ways that we can fix it. Now, next cause that is very common is psychogenic ED. So psychogenic is basically everyone who has ED, right? Meaning once you have an issue with an erection, it's on your mind. You're thinking about it, you're stressed about it. You're going into a sexual encounter being like, oh my God, am I going to have an erection that lasts
Mm.
long enough for me to have sex? Right. And so you're thinking about that rather than thinking about the pleasure in front of you. And so you're stressed, and then you're not going to have an erection, and then your anxiety gets worse. And it's just this vicious cycle. So I say everyone has some degree of that, right? No one is like, oh, my erections aren't working, I'm just fine. Like, you're stressed about it. Then there's hormonal. So a lot of people mistakenly think that it's all testosterone. And while testosterone plays an important role, and when it's low, especially at a certain level of low, you're very likely to have ED related to testosterone being low. Now, it's not always solely from low testosterone. So only about 3 to 6% of guys who have ED will it be completely fixed by just treating their low testosterone. But it's often helpful if you do have low testosterone to get treated, because you will see an improvement in erections, particularly those nighttime erections. And I just want to take a point to talk about those nighttime erections. They're really, really important. So a lot of people are like,
Mm.
how can I stop this? Why am I having these nighttime erections? But they're a good sign of health. It's when you're
Yeah.
getting blood flow to the penis throughout the night, because at a baseline, the penis is at a low oxygen state. So when you have these nighttime erections, it's your body's way of protecting the tissue. It's giving it good, healthy blood flow throughout the night, whether you're having sex or not, whether you're masturbating or not, whether you're getting erections during the day or not. This is your body's way of saying, I don't care if you do those things or not, we're going to protect your body, keep it healthy, keep the penis functioning. And then there's, neurologic causes, which could be like if you have multiple sclerosis, if you have nerve injury, if you've had a bowel surgery, sometimes the nerves get affected. There's a variety of things in the neurologic realm, and then lastly, iatrogenic or medication causes. So usually things like antidepressants, certain blood pressure medications, and very recently I learned that even sometimes NSAIDs, chronic NSAID use,
Mm.
so medications like anti-inflammatories, Aleve, naproxen, ibuprofen, those sorts of things may be linked to it. Now, not 100% clear, but I read one study where that was potentially a cause.
I guess, with the rising rates of metabolic conditions and chronic diseases, a bulk of the erectile dysfunction issues may come under, the first category where it's something to do with the heart or some sort of plaque buildup in arteries and atherosclerosis. But what I find interesting, and although, we can't say for sure based on an abundance of data, but like you said, what's good for the heart is good for the penis. And we know that a lot of the good things for the heart is something that the blood vessels produce. The lining of the blood vessels produce nitric oxide, which, widens the blood vessels, vasodilates them. And I guess that same thing can happen in the penis as well if we can somehow increase the amount of nitric oxide. Now, I had a really interesting conversation recently with a cocoa expert who said that actually dark chocolate and the flavonols in dark chocolate can trigger the nitric oxide production even more. And I guess not just cocoa, but a lot of the substances and polyphenols and antioxidants found in dark leafy greens and other things can also do a similar thing as well and increase nitric oxide production, right?
Absolutely. So yeah, there's actually been studies looking at chocolate intake and different. There's actually a very large study looking at what is called the NHANES data, which is essentially really wide surveyed group of people who are representative of the general population in the United States, and they looked at like dietary intake, and they found that those who take more flavonoids had lower rates of ED. So yeah, adding things like dark chocolate, like arugula and kale and beets, all of those things, those have dietary nitrates. Some of those things cause increase in nitric oxide, and they can then help sort of, I call nitric oxide the ignition for erections, right? You need to
Mm.
have nitric oxide in order to get an erection. And usually you need some stimulation for that to happen, right? You need to see something, hear something, feel something that then causes your endothelium to release this nitric oxide and then causes the relaxation to let blood flow into the penis. And so absolutely. The diet is so important for erections. And usually what I just say is, there's a lot of data out there and you can get really confused as to like, oh, should I eat this every day? Should I eat that? There's even one study on pistachios and how it improves sexual health. And like, you can get really in the weeds and be like, oh, I should eat pistachios every day. I should eat dark chocolate every day. I should eat this. You should eat whole foods that are
Yeah.
generally going to be healthy in terms of like you're trying to eat lower saturated fat. You're trying to get, a good amount of antioxidants through fruits and vegetables. Now, whatever those are, whatever you enjoy, right? If you don't like dark chocolate, don't force yourself to eat it, right? And so I think that's really the key, trying to minimize highly palatable processed foods and, just like making sure that you're getting a good balanced diet and your numbers are on track, meaning your cholesterol's in good order because there's genetic factors too. So I think it's really more complex than just eating, some dark chocolate or leafy greens. Those are great if you like them and you can incorporate them in your diet.
I guess one way to assist men in having erections, which also should not be, made taboo, is, chemical means, medication like Viagra, for example. And I see a lot of people using Viagra a lot more, particularly when they don't need it. And on social media, I've seen a lot of adverts for various Viagra type or mimics or substances like that, which are actually targeted towards a younger demographic, which, you'd think wouldn't need Viagra. I typically grew up thinking Viagra is something that someone, in their 70s or 80s might need to have some extra boost or assistance with an erection. But now it seems it's widely prevalent in, teenagers, people in their 20s, 30s, and 40s. And actually, I wonder whether there is any evidence that you can have some sort of rebound, erectile dysfunction with excessive Viagra use. And actually, can it be harmful to use Viagra when it's not needed?
Yeah. So, one, I want to debunk the myth that young men don't get ED. Unfortunately, there's actually 20 to 30% of men under 40 have experienced some issues with erections. Now,
Hmm.
the causes are not all you would think. A lot of people will think, oh, they're all just in their head, right? It's just psychogenic. And yes, we're seeing a lot of that because there is this rise in accessibility to watching pornography, which then sets up unrealistic expectations for what sex is supposed to look like. And when you don't have good sex education and that's the only place you're looking at to learn about sex, that can be quite harmful. Now, but when you look at the data, in fact, they find that 87% of guys under 40 who have issues, like true issues with erections, actually have an organic cause too. And so while it's a small subset of guys who are experiencing this, and even and smaller than that is all organic, but it is definitely there. So it's still valuable to do all the things we talked about. Now,
Yeah.
in
Yeah.
terms of using Viagra, a lot of times these guys are then like, well, I don't want to see a doctor. I'm going to use one of these online services to get access to these medications and try them. Now, if you're using them recreationally, the issue is that it sets a set point, right? Like you are used to getting this little
Hmm.
boost when you try to get an erection. And then when you go off these medications, you can sort of start feeling one, a psychogenic dependence, like, oh, I need this. And two, you might say, hey, my erection's not as robust as it was with the medication. So now you feel like you have this perceived view that things are less robust as they used to be, but really they're normal. They're just what they would have been without the medication. And so that's the issue. And I think that oftentimes, using them if you do have a psychogenic issue is not actually harmful and sometimes can be helpful. I mean, there's two sides to the coin. Some people can develop this perceived dependence on these medications, but then there's other guys who can use it and be like, okay, wow, I have the confidence back. I can get good erections. Now the psychogenic issue is actually going away. Right now, I'm not stressed when I have sex. Now I'm feeling good. And I can start sort of weaning off these medications. And because I don't have the stress in my mind about erections, now I've sort of overcame that. Now it's best to do that with, some form of sex therapy or to talk to a psychologist because that's going to help you the most in terms of dealing with those thoughts and anxieties. But if you can't, these are the other alternatives that we have.
Yeah, I feel that, more so than men, being targeted for medical use, it seems to be targeted for recreational use, which was my main concern. But I do appreciate that point. That's a really good point, actually, you made, that it can provide and empower men to get a bit more confidence and then not be dependent on that. And interestingly, I found that although men find things like this quite taboo to talk about, one thing which seems almost less taboo in some instances is penis size. There's kind of classic male obsession with penis size, and sort of this obsession with the link between penis size being more manly and also penis size determining the quality or physicality of the sex that you might have as well. When you see patients in clinic, particularly young men, do you often ever sort of get consulted when people are asking about their penis size or being obsessive about it being too small or it being a certain shape?
Yeah, absolutely. I mean, we'll talk about size first. So, in terms of length, I think every guy has thought about their penis length at some point in time in their life. Now, do they talk about with me? Maybe not. But usually, at some point, especially because of the accessibility of pornography and seeing anatomy that is, enhanced through looking at, where the camera's positioned, and obviously actors in the adult entertainment industry tend to be those actors because they are on the higher spectrum of size, tends to start making you feel like you're less than average. And average, just for people, is about 5.4 inches. So I don't know the centimeters on that, but it's about I think it's like 13 centimeters, but 5.4 inches. And so that's average around the world. It's different, if you go to the East versus the West versus
Yeah.
look at just, but generally 5.4 inches. So that's average. And, that is going to fit the average vaginal length, which is about 3.7 inches, which does expand a bit with arousal. So it may increase in length by 1.5 to 2 inches. And so, you're going to fit the average female. And so, generally speaking, you should be able to have wonderful, pleasurable sex. But the more important thing is to realize that the large majority of women, 80% or more, need clitoral stimulation to have an
Mm.
orgasm, which means that it doesn't matter how long your penis is. If you're not actually stimulating the clitoris, you're not doing your job in terms of providing your partner pleasure. And so, there is this perception, right, that bigger is better, and everyone falls victim to it because we hear about it all the time. People will joke about it, even when you're kids. I mean, my son will talk about how, like, you know, uh, ask questions about penis size and how do you make it bigger, because kids are talking about it, right? And I think that it's pervasive in society, but certainly not necessary for pleasure, and absolutely not necessary to have a good sex life or a very, robust and exciting and virile and, amazing sort of time with your partner.
Yeah, I think that point that you made about sort of heterosexual sex is really key there, because obviously for women the density of those nerve receptors are highest around the labia, around the clitoris, and like you said, most women have clitoral orgasms, not orgasm via penetration or vaginal orgasms, which is actually in the minority of women. And I think up to 1 to 2 inches of the vaginal canal, you still see a high density of nerve receptors, and it decreases in density the deeper you go. So it doesn't really make sense that someone should equate size with pleasure necessarily. And I guess even though we talk about this and we talk about size not mattering, there are still ways and means in which men are catered towards increasing their size. You've got these strange traction devices you can buy online, sort of adding weight to the end of your penis. There's even penis lengthening surgery where they'll, snip a bit of the ligament that's attached to your pubic bone to make it flop out a bit more. I mean, while some of these things exist and some surgeons offer this almost like, the cosmetic version for genitalia, how dangerous is that? Because a lot of these things can actually result in tissue injury to the penis, which could actually affect the length of the penis when it comes to erection, because, these things might offer an increased length when the penis is flaccid or not hard, but when someone then has an erection, they may either fail to get an erection because of the tissue injury, or, they might not get a proper erection, or it might even be painful because of scar tissue buildup eventually.
Yeah, so in terms of like traction therapy, that's generally safe if you're not going crazy with it, right? Like I tell my patients, like, I'm going to tell you to do this. Don't go crazy. Like if I tell a man to do something, he's going to do it like 10x, right? So I'm like, no, do it
Yeah.
1x. Like do it exactly how we're describing it to be
Don't
done.
don't don't lift weights to failure with your penis.
Yeah, please don't, please. Yeah, because right, if you're pulling on the tissues, you're also pulling on the
Yeah.
nerves, right? And so you're going to
Yeah.
create traction injuries if you pull too hard and too often. And to be honest, the studies on traction, like they're like 6 to 8 hours of traction a day to see a 2 centimeter increase in size. So you really
Wow.
need to be um, committed and very into it to get those results. Now, there's some newer traction devices that you can do 30 minutes twice a day, but that's still quite an investment of time, right? And, we don't know that, like, okay, say you do traction for 6 months or 3 months and then you stop. Like, how long do those gains actually remain? Like, are
Yeah.
they just going to
Yeah.
stay that way forever? And then in terms of surgery, like the ligament, cutting the ligament, the suspensory
Mm.
ligament, that is, again, typically just going to increase flaccid length. And it actually makes the
Mm.
penis a bit unstable when you get an erection. So it's not going to be as that could then subsequently, when you're having sex, if you have a less stable penis, put you at higher risk for something like a penile
Yeah.
fracture, which is a much more serious issue. Now, it does work, but it can scar back, right? So if you do cut this ligament, then it might scar back, and then you might just have gone through a surgery and pain and the subsequent possible injuries to nerve, like as you mentioned, during surgery, which then cause more harm than good. So I often tell people, look, there's a lot out there. There's data on a variety of different surgical procedures to increase length or girth, but they all have risks of maybe things contracting down and actually being shorter than when you started, risks of injury, nerve injury, sensation, and worst case scenario, you're getting disfiguration. And so I think, or erectile dysfunction. And I think that there's really serious considerations to be thought about before you do anything. That do you really need to do it, right? And the more important and pressing issue is some people have what's called small penis anxiety. So
Mm.
Small penis anxiety is like you are preoccupied with the size of your penis. Now, this is not a large percentage of people, but there are men who are like constantly thinking about this. And this is a sign, and it's causing distress throughout their life. And this is a sign that this is a psychological issue that needs to be addressed before you have any sort of cosmetic or, enhancement type of surgery. And most good surgeons will make sure that, especially if they're doing these type of surgeries, will make sure that that's addressed. But if someone's like, you want this? Yeah, you got it. And they're not doing any sort of evaluation
Yeah.
of your mental state, then that is not the surgeon you want to work with.
No, absolutely. I mean, I guess, we've spoken about the sort of penis, which, a lot of men shy away from talking about, particularly when it comes to problems. And even though it's kind of, right there, can be physically seen. And we briefly touched on something else, which a lot of people don't talk about. It's a bit, obviously, a lot more hidden, which is the prostate. What are some, commonly the kind of aphorism which is quoted, the sort of phrase which is quoted is that most men, die with prostate cancer rather than from prostate cancer, suggesting that, it's an indolent disease, which kind of, most people can probably live with unless it spreads to, other, body parts. And usually, people will die of old age rather than dying of prostate cancer. But, I wouldn't want to underestimate the burden of prostate cancer and, just kind of be blasé about it. So when someone is, looking at sort of, prostate problems, what are some red flag signs that should make them think, you know what, let me go and see my doctor to either get a PSA, prostate specific antigen test, let me get a digital rectal examination, let me get some sort of test to get this seen to?
So there are no signs in early prostate cancer, right? So if you are above the age of 50, or below the age of 69, generally it's recommended to get screened. And the reason we say 69 is that the average age, these are based on average ages, right? So when you have, let's say, 10 to 15 years of life expectancy left. So the way I tell people to think about that is think about your dad, right? There's a genetic
Yeah.
component. And when did they pass away? And if you are of similar health, you will likely pass away around the same age. And so if you are within 10 to 15 years of that age, you probably don't need any sort of screening at that point because, as you mentioned, likely you're going to die of other causes or natural causes before the prostate cancer becomes an issue. The issue becomes when you have more than 10 to 15 years of age and you are at risk for prostate cancer, you need to be screened. It's important to be screened. Now, it's supposed to be a shared decision-making discussion with you and your doctor. And the reason of that is because the treatments for prostate cancer are not benign, meaning there are risks and side
Yeah.
effects that happen with prostate cancer treatment. And, if you come with a low grade, like 1% of prostate cancer in a biopsy, like what do you do with that? Is that going to become a serious problem? And a lot of those people can probably go on and go through what's called watchful waiting or active surveillance and may not have a problem. So every point at which you do something for prostate cancer, you are now having to make a new decision based on new data, and that can lead to anxiety. So it is important to talk to your doctor about this. But generally speaking, if you're a young man or if you have a family history or if you're African American or have some genetic predisposition to cancer, you should get some screening test in your 40, 45 age, at least one, to kind of get a baseline. And then usually after 50, we say get it every 2 years to follow your PSA to make sure that we're making as a screening test for prostate cancer. And again, this is complex because if you get diagnosed with a higher grade prostate cancer at a young age, it's going to cause a problem, right? You're going to get metastatic prostate cancer at some point in your life if you do nothing. Whereas if you get a lower grade, maybe that won't become a problem. So it is sort of hard to determine, without the data, without getting
Hmm.
screened, without knowing which one you're going to fall into if you are
Yeah.
unlucky enough to get prostate cancer. And so that's why screening is important. And really, it is valuable because before we had PSA, we had men coming to the emergency room with severe back pain from metastatic prostate cancer all the time. And, at
Hmm.
that point, we didn't have the advances in medication that we do now to treat this. So the older urologists used to have to do just orchiectomies, meaning remove the testicles to stop testosterone to help with the pain because these patients were miserable. And so it is something that needs to be screened for. It's sort of the frequency of screening and what you do with that information that can be variable depending on your individual circumstance.
Now, obviously, when it comes to lowering someone's risk for, cancers, all cancers are different, but I guess they share, some similar sort of common denominators when it comes to risk reduction. Like sleeping better, making sure you have a higher fiber diet, keeping a healthy weight, exercising, not smoking, limiting alcohol, so on. One famous study, which is often commonly quoted when it comes to prostate cancer, comes from this sort of survey-based epidemiological study where it suggested that masturbating 30 times a month lowered prostate cancer risk. Now, I can't understand mechanistically why that would work. And is that, in your opinion, just more correlation rather than any sort of specific cause that actually results in masturbation and orgasm reducing the risk of prostate cancer?
Yeah, so the study was looking at men who masturbated, and they actually put them in two categories. So, did you masturbate 4 to 7 times a month, 7 to 14, 14 to 21, and I think those were and over 21. So, what they found was that the men who masturbated 21 times or more a month were less likely to get prostate cancer than those who did less than 7 times a month or 4 to 7 times a month. So, of course, these studies need to be taken with a grain of salt, but this study did a pretty good job of trying to control for a lot of different factors that may be correlated with prostate cancer. Now, you can't correlate for everything, right? So you think about the person who, first of all, mechanistically, how might this work? So thought is that there's fluids in the prostate that are just sort of sitting there, right? And when you masturbate, you're sort of cleaning the pipes. You're sort of getting rid of that stagnant fluid that may allow buildup of free radicals and other issues that may lead to transformation of the cells causing cancer. And so that's the theory behind it. Now, the other thing is the person who's doing that 21 times or more a month, that it's not masturbating, it's ejaculating. So it could be
Mm,
having sex, masturbating, whatever. But they may have better relationships. They may be happier.
yeah.
They may be more physically active if they're having sex 21 times a month, right? There's a lot of factors there that go into someone who has a healthy and happy sex life. And also orgasms have a multitude of benefits. And there's just not a lot of study on orgasm, right? But we know that it causes decreased heart rate, it helps with sleep, it helps with stress. And so all those factors are going to play a role in terms of potential cancer development. And so I think what I take away from that study is it's it's okay to masturbate, right? Like I think there's no reason not to if you're doing it and you're not having problems in your life, it's not overtaking you and you're not wanting to masturbate rather than be with your partner or masturbate rather than go to work, right? Like it's fine. And two, it's something that is helpful because of potentially this hypothesis. So one, that's true. And then two, like do you have to reach 21 times or 30 times or whatever? No, no, just do what you normally would. But there's value in terms of having a healthy, functioning, good sex life, right? Someone who has ED is not having 21 times a month of orgasm potentially, or masturbation or ejaculation. And so I think it all factors into it. And ultimately, the take home for me is just enjoy your sex life as you see fit and continue all the healthy behaviors that come along with having a functioning penis and an active sex life, which may be stress reduction, happiness, or regular orgasms, all those things.
I feel that, the women are feeling left out of this conversation because we've spoken a lot about male problems in the bedroom. And, when it comes to pelvic floor issues, people either don't know what the pelvic floor does or they underestimate this. They see this as some sort of mythical beast, but not only does it, contribute to bowel function, bladder function, sexual function as well, and just sort of general well-being and core strength. I guess, this can impact women more so than men because they have more pelvic organs in that region, which are dependent on the pelvic floor. And I guess a lot of people also have this misconception that the pelvic floor muscles and the pelvic region is all just generally about weakness. But both from your experience and my experience in dealing with such patients, even overly tight pelvic floors and even poorly coordinated pelvic floors can be a problem. And like you alluded to earlier, if someone as a stress response is squeezing their pelvic floor, either if they're in the toilet or in the bedroom, this can lead to problems from constipation to pain, even pain during sex. What are the most kind of common sexual dysfunction issues that you see in women?
I mean, there's so many. So, in terms of, I would say the most common is low libido. 40% of
Mm,
women experience low libido or low sex drive. Only 12% are bothered by it, according to the studies, but it's very, very common. And I think the reason for that, and we'll definitely get to the pelvic floor, but the reason for that is often because what happens is when you think about desire, most people think of it as spontaneous desire. You see your partner, you immediately want to
mm,
have sex with them. There's no like build up or anything. You're just like, you're ready to go. But what happens, especially in long term relationships or as you know, as you age potentially and you have more stressors, is you have what's called responsive desire. And men can have it too. It's not just women, but it's very common in women where you need to sort of allow yourself to feel intimacy before you can get that desire to come. So, sort of like you need to be aroused a little bit, and then you're like, oh, yeah, I used to like this. I want this, but I didn't
mm.
think I wanted it. It's like going to the gym, right? You don't actually want to go, but once you're there, you're happy you did.
Yeah.
So, if you sort of are intimate with your partner, you're close to them, you're physically, cuddling or being together, and they're like, oh, wait, yeah, now the desire is there. It wasn't there when you asked me if I wanted to have sex, but it's there now that we're actually being intimate and I'm getting turned on. And so that is actually normal, right? That's a normal function, but oftentimes that's not what's happening in real life. And so you're sort of feeling like, wait, something's wrong with me. I have no spontaneous desire anymore, and now I'm broken. And there's obviously treatments for low desire and things that we evaluate if you still feel like you have low desire and you're struggling with it, because menopausal changes can lead to low desire as well, changes in hormones and things like that. So there are obviously medical causes of it, but a lot of times it's because of this responsive desire. Now, in terms of other issues, we'll see is pain with sex is quite common
Mm,
because of this pelvic floor issue. So oftentimes, when the pelvic floor is tight, and it's, you would think like, who has a tight pelvic floor? I can't tell you just by looking at you, but certainly people who have more anxiety, more type A personalities are more likely to have a tight pelvic floor. If you have sort of abnormal behaviors for your whole life, like you hold your urine a lot, like we see a lot of nurses or teachers who tend to hold their pee all day long because they're busy, right? And then they start having dysfunction in their pelvic floor because they've been clenching that pelvic floor for years and years and years, right? And so you will see people or people who sit all day long. Like during COVID, we saw a huge rise in people with pelvic floor dysfunction because they were literally sitting all day long working from home and not getting any
mm,
movement at all. So it absolutely happens, and then it can cause this variety of symptoms, pain being one of them, and then the urinary symptoms, and sometimes even muted orgasm or things of that nature. So that's one cause of it. The other cause of pain with sex is oftentimes during perimenopause or menopause, where you're losing vaginal estrogen, and that causes a decrease in lubrication, and that makes sex uncomfortable, and that can be very well treated with vaginal estrogen or any sort of treatment, that you can get over the counter moisturizers and lubricants and things that can help a little bit. And so those are things that are rather common. But we do see women with difficult, like having decreased strength of their orgasm, decreased arousal, so they feel less lubrication and things like that. So there's a whole host of things that come into play, but I would say that the most common are those that we talked about.
I guess, when we talk about pelvic floor issues, you mentioned there that obviously sex is a huge component, and also failing to achieve orgasm can be a consequence of, a pelvic floor issue. Another common one, one of the main organs in the pelvic floor, or two main organs, the sort of the rectum and the bladder. And probably more so in women that I've seen, particularly than in men, they have issues with continence, with urination, and with, feces as well. More so, you see that in women, probably because they are more predisposed to pelvic floor issues than men, due to maybe, lower muscle mass on average, having more organs, childbirth, periods, chronic gynecological conditions. All of these things can increase the likelihood of these problems. Just from the bat, I mean, having these things might make a woman more sort of embarrassed to get intimate with a partner if they're kind of, soiling themselves, or they're feeling sort of some hygiene issues. But also on a practical level, day to day, this might limit them going for a run, going to the gym, going out to the shops. Often when I see a patient who's got both a combination of fecal discharge or fecal incontinence and bladder incontinence as well, they actually tell me, I don't feel like I can leave the house because last time I went to buy something at the grocery store, I needed to use the toilet. I had to run back to my car and she soiled herself in her car. And for me, I can't even imagine a situation like that, but I can see how awful and distressing that must be. What can someone do about that to sort of begin to fix that?
Yeah. So, first of all, we call this overactive bladder, right? You get this urge, this sudden desire to go to the bathroom. You can't delay, and sometimes that leads to incontinence. Now, the other cause of incontinence is stress incontinence, right? That's when you cough, sneeze, lift something heavy, do anything that increases pressure in your belly that causes you to leak. And that is due to weak pelvic floor muscles. Now, they both have very different treatment options. And I will just preface to say that men also have urgency incontinence at times, and oftentimes it's due to enlarged prostate. But for women, let's talk about overactive bladder. So, overactive bladder is caused because your bladder is having spasms, right? It's having spasms before it's completely full, and it's telling you, hey, you got to go. And so, usually, most people will have that urge, but they can delay it, right? They can walk calmly to the bathroom, get there, pee, and leave, right? Sometimes it's stronger than others if you wait too long, but for most people, it's not a huge issue. But these people who have issues, right? They can't make it to their car. They can't make it to the bathroom. It's horrible and it's embarrassing. And so, first is like, why is this happening, right? Sometimes it's due to a neurologic condition like multiple sclerosis or other neurologic issues. Sometimes it's due to changes in the pelvic floor, as we mentioned. So when you have tenseness in your pelvic floor, it's basically a trigger that your bladder is feeling like, oh, I got to go, I got to go. Sometimes it's even a learned behavior, right? Like you constantly go just in case, and your brain starts thinking like, hey, your bladder is smaller than it actually is. And it makes you feel the urge to go more often. Sometimes it's due to a prior surgery. So if you've had any sort of surgery that will sort of make the ability to urinate less able. So something like a mid-urethral sling or a sling which we use for stress incontinence. If it's too tight and it's making it hard to pee, your bladder is then responding by having more spasms. And sometimes it's due to medication. So if you're on like water pills or other medications, you're getting a lot more fluid through your bladder, and it may make you go more often. Diabetes can very often cause this. It actually changes the bladder muscles themselves to make them more overactive. So, a variety of different things can cause it. Sometimes we don't know what causes it. It may be something we haven't accounted for, but ultimately, the treatment of it is there's a variety of things we can do. So, starting from like least invasive to most invasive, least invasive, you can start by just like I mentioned, there's a little bit of sometimes behavioral changes. So, you can do what's called bladder training. You can, first of all, write a little diary, write down how much you're drinking, how much you're peeing. You can estimate that, or you can get a little measurement device to actually measure it. And you could take a look at what you're drinking and eating and seeing like, oh, is something causing me to pee more? Very often the culprit is coffee or caffeine or some soda, or it can be alcohol. You often notice that these things can irritate the bladder lining, making you need to pee more. Also, other things that affect some people, but not everybody, are artificial sweeteners, citrusy fruits and juices, tomato-based products, carbonate. I said carbonate. So yeah, those sorts of things can cause irritation to the bladder lining for some people, not everybody. And so it can be useful to sort of just investigate what's going on, right? Also, a lot of people are drinking a lot these days. So they're walking around with their
Mm.
Stanley cups, which are huge, and they're drinking all day long. And so they're going to pee a lot, right? And so it seems simple, but if you cut back your fluid intake, and I tell people just to look at the color of your urine,
Yeah.
right? If it's clear, you're drinking too much. If it's dark yellow, you're drinking too little. So it needs to be like a lemonade yellow. It's a great self regulator. Your body is wonderful. It sort of takes care of a lot of it, but it does tell you that you're getting enough. And so that may be a good way to assess that. Constipation is a big contributor because, as you know, the rectum
Mm.
is right behind the bladder. And so when it gets full, it tells the bladder, hey, something is here pushing on me. Maybe I need to go pee. It can also cause retention in some people. So if you're
Yeah.
having struggle peeing, the opposite can happen. It can make it more difficult to pee. And so treating your constipation is super important. If you smoke, that's going to cause irritation as well. So trying to quit smoking would be great. And then, maintaining a healthy body weight. So we know that when you lose about 8% of your body weight, you will improve your urinary symptoms. This is for overweight or obese patients, that weight loss can be helpful. So those are sort of the easy things that you can do. And then, you go on to medications that are available, and then there are procedures. So there's things like Botox in the bladder or a bladder pacemaker, or there's an acupuncture like treatment that we can offer in the ankle. And so there's a whole bunch of things that we have available to us to help with overactive bladder. So I think that's the good news about it.
I think, most people don't really understand that, the pelvic floor muscles is something that we should constantly be training throughout life rather than only fixating on it when we have a problem. And really interestingly, when I was a medical student, I sat in a colorectal pelvic floor physiotherapist clinic session, and she was explaining to a patient about training their pelvic floor. And the analogy she gave was that I don't want you just to squeeze your buttocks together like, you're just kind of pulling them tight and, sitting down on a hard surface or something. I want you to imagine like you're trying to hold in a fart. And that sort of clenching you do, the clenching of the sphincters, almost the internal sphincters, like you're trying to prevent a fart from escaping. Like she actually said this, almost verbatim as I can remember it from over, 15, 16 years ago. Imagine you're on a date with a beautiful person and the date's going really well and you want another date and, you're at dinner, but you feel a fart brewing. And you don't want the fart to leak out and ruin the date, ruin your chances of having a second one. So you try and keep it inside and keep it from bubbling outside. That is how you train your pelvic floor. And she said to the patient, do that, 10 reps of that holding in a fart for how many times you want. And, that's something I guess more people should be cognizant of. Beyond doing these kind of simple, things like that, which can be done silently anyway. You could be standing in a queue at a bank and trying to hold in a fart and training your pelvic floor. You could be watching TV. Beyond that, and, obviously avoiding some of the things you mentioned, some irritants like excessive water intake, excessive caffeine, alcohol, various irritants like that. What are some things that the average person can do to actually preemptively and proactively begin to train their pelvic floor on a daily basis?
Yeah, so I think that the more important thing is just having normal function, right? So our pelvic floor is involved in everything you do. Every step you take, it is involved in stability. It's involved in, even managing sort of like lymphatic drainage and trying to help with that. And so there's a lot of functions of the pelvic floor in addition to the dysfunctions we've talked about. So
Yeah.
one is, maintaining good pelvic floor, like walking regularly, not sitting all day, doing exercises that allow lengthening of the pelvic floor. So you don't, especially when you're doing anything strenuous, you want to make sure you're breathing okay, right? So you're not always holding your breath and doing bicep curls. Like you want to make sure you're breathing throughout, exhale on exertion. That's so that your pelvic floor is working in concert with your muscles. So you're not straining against it. So that's one. Another one is, we've talked about this a little bit, but making sure you're not like constantly holding in your urine or your stool, right? You're going at a regular
Yeah.
basis. You're not doing it all the time. Of course, once in a while, like you're in a situation you have to hold it. That's fine, but you don't want to be doing it all the time. And don't hover to pee for women, right? So a lot of times you will hover over the toilet, but you're not actually relaxing your pelvic floor then, you're tensing it
Mm,
up. And so if you're peeing through a tense pelvic floor, one, you're not going to empty your bladder, so you're at higher risk for UTIs, and two, your bladder is getting trained to pee in this dysfunctional way, right? So that's another thing you can do. Now, diaphragmatic breathing is another thing you can do to sort of lengthen and stretch the pelvic floor. So sort of big, deep breaths that go into the belly, not just the chest. And then there's certain exercises you can incorporate into your routine. Yoga exercises are really helpful, like happy baby pose or child's pose, or even like low, deep squats. All those things will help lengthen the pelvic floor to allow for good, healthy, normal function. And then if you do these Kegel exercises or strengthening exercises, you don't want to overdo it, right? There needs to be a balance between that and the stretching exercises. So if you do it, you want to make sure you clench, relax, clench, relax, clench, relax. And you described one really well, which is holding in a fart. The other one that we'll say is you can practice it when you're peeing. Don't do it every time you're peeing, but just to learn where the muscles are, stop the stream in the middle of a pee. Or sometimes we'll tell guys like it's as if you're trying to lift your penis off the floor without touching it.
yeah.
All right, so that's using those muscles. And for women, it's sort of trying to pull up and in the vagina. So there's like a whole bunch of different things that you can use to help you visualize those muscles. And fortunately on YouTube, there's a wonderful physical therapist teaching people how to do this. But more is not always better. You do it to strengthen, but if you overdo it, you're going to
Yeah.
develop this tight pelvic floor. So I think those are all things that you can do. But generally speaking, if you're having normal function, it's not something you need to think about regularly. So if you're urinating normally, you're having normal defecation, you're not having pain, that's great. If you develop, the other thing that sometimes people don't realize is that if you develop like labral tears or hip issues, sometimes that can destabilize the pelvic floor. So
Yeah.
that's another time where getting a physical therapist involved might be helpful. So ultimately, I think trying to have normal function, trying to make sure you're not constantly holding your breath, holding your urine, holding your stool, those things are going to help prevent dysfunction down the line.
I guess, in addition to one of the things you mentioned about sort of, the sort of malcoordination of the pelvic floor is not trying to force the issue as well. I've found over the years a lot of patients who strain, who maybe even force out their urine in like a fast stream. Actually, when things are leaving your body, whether it's urine or feces or farts, it usually does so in a coordinated way where the pelvic floor is relaxed and it's more open and it's more lax. But if you're forcing it, you're actually tightening everything. So down the line, if you're constantly forcing out urine from your bladder, forcing out feces, you're actually contracting that pelvic floor. You get that paradoxical contraction. And actually, over time, it can sort of lead to a weakening of the pelvic floor muscles over time. And, we could have this conversation just about pelvic floors or just about urine, I guess. But what I want to say is I really love the way you sort of demystify and de-taboo, if that's a word, all of these things to do with pelvic floor habits, pelvic floor health, sex, and kind of genitalia, which I really feel is, a lot of people have these issues, are concerned about these issues, but they don't really vocalize them. So it's really good to have people like you talking about them. And hopefully during this conversation, listening to this, someone can take away some real actionables. And even if they're not comfortable talking about their penises or, stress incontinence problems with their friends, hopefully now they can use this as a reminder to go to their doctor. So thank you very much.
You're very welcome. And thank you so much for having me.
Thanks again to Dr. Rena Malik. Has opening up about embarrassing health problems ever been a lifesaver for you? Do you feel more comfortable talking about them now? Let me know in the comments. And make sure you subscribe so you don't miss the weekly Dr. Karan Explores podcast, and I'll see you fleshy wonders next week.